Vanakkam. When we talk about metacarpal neck fractures, we'll be seeing them quite often, and that's not surprising since the commonest type of finger metacarpal fracture is the metacarpal neck fracture. But that doesn't mean that the treatment is anyway simple. There are so many methods of treatment, and since most of these metacarpal neck fractures are closed injuries, the decision to whether to open it or do a fixation percutaneously is quite important. We shall be seeing all these methods of management of metacarpal neck fractures, their advantages, their disadvantages, and the technique in this video. Fractures of the neck of the finger metacarpal can occur with the index, middle, ring or little finger metacarpals. But the fifth metacarpal neck fracture is the commonest, sometimes known as the boxer's fracture. It doesn't actually occur more in boxers but more when a person hits out at a solid object like a wall. This accounts for almost 50% of all metacarpal fractures. The clinical features of metacarpal fractures has been discussed in an earlier video, and the features of metacarpal neck fractures are similar. That is, the commonest findings are extensor lag of the finger, as can be seen in this clinical example, a pseudoclaw deformity, shortening sometimes, angulation which is characteristic of metacarpal neck fractures and seen mainly on X-ray, and rotation deformity which can be seen by rotation of the fingertip. The reason for each of these deformities and the detailed assessment has been discussed in the earlier video, which can be accessed by clicking on the icon above. Having understood the clinical presentation of the metacarpal neck fracture and the assessment of this fracture, we need to then discuss the treatment procedure. This will consist of three important steps: reduction of the fracture, immobilization of the reduced fracture, and therapy. The first step is the reduction of the fracture. How do we reduce the angulated metacarpal neck fracture? The Jazz maneuver, described way back in 1938, gives the answer. The basic step here in this maneuver is the flexion of the metacarpophalangeal joint of the involved finger to 90 degrees. When the metacarpophalangeal joint is flexed to 90 degrees, the intrinsic muscles which cross on the volar side of the metacarpophalangeal joint becomes relaxed and the collateral ligaments of the metacarpophalangeal joint become tight. So what happens is the distal fractured segment of the metacarpal and the proximal phalanx become a single unit, and so by exerting a dorsal force, the fractured metacarpal neck gets reduced. Just to show how it is being done, I shall be demonstrating the Jazz maneuver on a volunteer's hand. The first step is to flex the metacarpophalangeal joint of the involved finger by 90 degrees, then flex the proximal interphalangeal joint by another 90 degrees, and then with the locked proximal phalanx and metacarpophalangeal joints, a dorsal push is given to reduce the metacarpal neck fracture. The Jazz maneuver remains the best technique of closed reduction of metacarpal neck fractures, but it is only the first step in the management of the fracture. It should be followed up either with a POP cast or closed fixation methods. Now that we have learnt how to reduce the metacarpal neck fracture, we need to now immobilize this fracture in the reduced position. This is essential for the healing of the fracture. This can be done by non-operative management or operative management. The non-operative management can be done with the POP slab or cast, and the operative management can be done either by percutaneous fixation of the reduced fracture or by open fixation. In performing the non-operative management, that is, in the form of a POP slab or cast application, there are a few important points to be considered. The first is the position. The metacarpophalangeal joint must be kept in 90 degrees of flexion and the interphalangeal joints should be kept straight. When applying the volar POP and flexing the metacarpophalangeal joint, we need to remember the natural curve of the metacarpal heads and design the POP in such a way that the flexion occurs at this level and not distally. If the POP does not provide 90-degree flexion at the metacarpophalangeal joint, the reduced fracture becomes unstable because the intrinsic muscles get stretched by the extended metacarpophalangeal joint. We also need to remember to provide a good molding of the fracture, the least padding should be used and gauze should be applied between the fingers. The POP slab should extend till the tips of the fingers. But there are some situations where this sort of conservative management with the POP will not be efficient or sufficient. The indications for operative management of metacarpal neck fractures are as follows. Open fractures with associated soft tissue injuries obviously needs fixation, as the soft tissue envelope is not enough to support conservative management of the fracture. Fractures of multiple metacarpals, even if it is a closed injury, requires open reduction and fixation. We have already seen in a previous video that rotational malalignment of even 1 degree will not be tolerated and operative management of that fracture must be done. Similarly, if there is shortening of the involved finger of more than 1 centimeter, operative management is required. Even the presence of significant pseudo-clawing of the finger is indication for operative management. And significant angulation, which can be remembered as follows, that is, more than 10 degrees of angulation for the index finger, more than 20 degrees for the mid finger, more than 30 degrees for the ring finger and more than 40 degrees for the little finger metacarpal need operative management. When we mean operative management, it could be percutaneous fixation or open fixation. Percutaneous fixation could be in the form of intramedullary screws, different uses of K-wires which could be retrograde intramedullary fixation, transfixation, cross K-wires or intramedullary fixation by the bouquet technique. Open fixation, on the other hand, could be by the use of K-wires, by a technique called tension band wiring, which can be done with stainless steel wires, or composite fixation, or by plate and screws. First, let us see the method of percutaneous fixation using intramedullary screw. First, closed fracture reduction by the Jazz maneuver needs to be done. Then, percutaneous retrograde insertion of a headless cannulated screw, otherwise known as a HCS, is done across the fracture. This is done till it is countersunk in the metacarpal head. The size of the headless cannulated screws used for metacarpal neck fixation varies between 3.5 and 4.5 millimeters. First, fracture reduction is done. Then, holding the metacarpophalangeal joint in 90 degrees of flexion, a retrograde K-wire is passed through the fracture. The headless cannulated screw is then threaded over this K-wire till it is countersunk in the head of the metacarpal. This is to ensure that it does not impinge on the free movement of the metacarpophalangeal joint. The advantages of the IM screw fixation are that there are lesser complications like pin track infection, tendon adhesion or stiffness. K-wires play a very important role in the management of metacarpal neck fractures. They can be used for percutaneous fixation or open fixation. There are 3 prescribed techniques of K-wire fixation using percutaneous technique apart from the regular intramedullary fixation. The first is the maintenance of closed reduction by percutaneous longitudinal or crossed K-wires fixation, and this is done under fluoroscopic guidance. 2 0.9 mm retrograde crossed K-wires are passed from lateral or dorsal portion of the metacarpal head into the shaft, and they should exit through the dorsal metacarpal shaft. This is to ensure good and semi-rigid fixation of the metacarpal neck fracture. The main disadvantage of this technique is that the pins may cross the joint surface and also impinge on the movement of the extensor tendons on the dorsal aspect. The second technique of percutaneous fixation using K-wires is the percutaneous transverse K-wire fixation to the adjoining metacarpal. It is ideal to use 2 K-wires distally and 1 K-wire proximally. Since there is no impingement of the extensor tendons, active flexion extension exercises of the fingers can be started 1 week after surgery. The third technique of percutaneous K-wire fixation for metacarpal neck fractures was described by Fouché and is known as the bokeh osteosynthesis. It was described in 1985. This technique is mainly used in displaced neck fractures of metacarpals, especially the fifth metacarpal, what we have already referred to as the boxer's fracture. The technique in which this method is done is as follows. The fracture is first reduced in closed fashion using the Jazz maneuver. A hole is made in the proximal ulnar metaphysis of the fifth metacarpal or in the other metacarpal bases, as the case may be. This hole is made by drilling at 90 degrees with a drill sleeve to protect against injury to the extensor tendons. After the hole is made, it is tilted to 60 degrees and the hole is enlarged with 3.2 mm drill bit. Through this hole, 2 or 3 K-wires of 1 mm or 1.25 mm are used depending on the caliber of the metacarpal that is being fixed. We must ensure that the blunt tip enters first so that it does not injure the cortex. This K-wire must be bent as follows before it is inserted. The tip is first bent for 20 degrees. 2 centimeters proximal to this bend that is made, a 10-degree bend is made. After measuring the length of the metacarpal which is going to be fixed, a 90-degree bend is made in the wire. This serves two purposes. One is it will enable us to hold the wire and manipulate the wire within the metacarpal, and secondly, it gives us an indication about which direction the wire has been pre-bent. Finally, an acute bend is made to prevent injury from the sharp end of the K-wire. 3 such blunt pre-bent K-wires are passed anti-grade down the medullary canal, across the fracture and into the subchondral bone of the metacarpal head. All this time, the bent tip must be pointing in the palmar direction. Wires are advanced into the medullary cavity either by applying a little force or by using a hammer across the fracture zone into the head. The position is checked using image intensification. The cortex should not be perforated or injured. After the K-wires reach the subcortical area of the metacarpal, they need to be rotated so that the bent tips are now pointing dorsally and diverging in slightly different directions like dorsoradial and dorsoulnar, and they should lie underneath the dorsal cortex of the head. This ensures 3-point fixation, and the K-wires are now then bent at the level of the entry portal and cut. The advantage of this technique is that it avoids manipulation at the fracture site. The downside of this technique is that it is slightly difficult technically, needs a C-arm, and pins can migrate either proximally or distally if not manipulated correctly. Active mobilization is started 2 weeks after confirming the position of the wires. At the same time, it is advisable to provide wrist stabilization with splint support. The K-wires can be removed at 6 weeks. We have already seen the indications for operative management of metacarpal neck fractures. Under operative management, the choice would be percutaneous fixation, but there are some situations where open fixation would be preferred. For instance, in open fractures, when C-arm facilities are not available, or or when expertise is not available. This surgery can be done under regional block in adults or under general anesthesia for children. A tourniquet needs to be used. For open fixation, an incision would have to be made over the involved metacarpal or between the involved metacarpals when multiple metacarpals are fractured. We may need to extend the incision in an S shape over the metacarpophalangeal joint in order to afford better exposure of the metacarpal neck and head. Once the skin incision is made, the extensor tendons and the sagittal bands would be encountered at the level of the neck. They can be retracted, or we may need to cut the sagittal bands for adequate exposure. Needless to say, the cut in the bands should be repaired after the surgical procedure. Now the fracture ends should be identified and debrided. A trial reduction needs to be done, and the JAS maneuver would be useful in this step. Now a 2.5 mm K-wire is passed in the proximal segment of the fractured bone to exit distal to the wrist. This must be achieved by placing the wrist in extreme flexion. After passing this wire, full unimpeded range of movement of the wrist must be confirmed. The wrist must at least be able to be brought to the neutral position. Then the fracture is reduced and the sharp end of the K-wire is advanced distally to engage in the cortical head. This will ensure a good purchase of the K-wire. Full unimpeded range of movement of the metacarpophalangeal joint of the finger must be confirmed. An example of open fixation with K-wire for a metacarpal neck fracture is shown here. The fixation has been done, and this shows the ultimate healing with available range of movements of the fingers. Tension band wiring is a technique which can be used for open fixation of metacarpal neck fractures. The basic principle of this technique is that it converts tension forces to compression forces and hence promotes bone healing. This can be achieved with either stainless steel wire or by composite fixation using both K-wires and stainless steel wires. The technique of using stainless steel wire for tension band wiring is as follows. Two transverse drill holes are made, one on either side of the metacarpal neck fracture. These holes are made by drilling K-wires. The fracture is reduced and a 26 gauge stainless steel wire is passed through the distal transverse hole and then brought out over the dorsum of the reduced metacarpal neck fracture and then passed again through the proximal transverse hole and then tightened in the form of a figure of 8. As the stainless steel wire is being tightened, it compresses the fracture and hence tension forces are converted to compression forces. An additional intramedullary K-wire may have to be inserted as described earlier to support this fixation. Tension band wiring of the metacarpal neck fracture can also be treated with composite fixation using cross K-wires and a stainless steel wire as shown in this diagram. This example shows tension band wiring using stainless steel wire and the range of movements available after the surgery. Plate and screws can also be used to fix metacarpal neck fractures. Both regular and locking plate and screws can be used. The advantage of using the locking plate and screws is that we may not need to do extensive periosteal stripping because the bone plate contact is not much required in the locking plate. Usually 5-hole plates are used with 3 bicortical screws proximally and 2 bicortical screws distally. Though the use of plate and screws provides high mechanical strength, there are a lot of possible complications like metacarpal head avascular necrosis due to extensive periosteal stripping, non-union, tendon irritation or attrition leading to rupture, and stiffness due to excessive soft tissue damage. Whatever the method of management of a metacarpal neck fracture, whether conservative with a POP application or an open fixation, Therapy is an integral part of the program. The aims of therapy are to prevent stiffness of the metacarpophalangeal joint, to get back the full range of movements, both active and passive, to prevent extensor tendon adhesions, and to prevent scar adherence to the skin. These aims can be achieved successfully by continuous scar massage, use of compression with a crepe bandage when the therapy is started, use of a detachable wrist stabilization splint to protect the healing metacarpal bones, and to concentrate on the active range of movement of the metacarpophalangeal joints. It would be ideal to remove the K-wires only after a good active range of movement has been achieved at the metacarpophalangeal joints. I hope you liked the video. I enjoyed making it. Please click on the shown links to see about the principles of finger metacarpal fracture management and the management of fractures of the metacarpal head. And do not forget to subscribe to stay connected with the latest in learning hand surgery, plastic surgery and trauma surgery. Vanakkam.